Pakistan Strategic Cartography for inviting me to have a case here. Today I would like to present the case just done 2 days back in the emergency. And I prepared here yesterday. This is a case of a 64-year-old female referred to Tabar Institute from the Gilgit. She was a newly diagnosed diabetes, hypertension, and no case of atrial fibrillation. Echo done at the Gilgit shows a EF of the 40%, moderate MI, referred here for the coronary angiogram. She was admitted for the coronary angiogram, but the cat deferred because she took the dual anticoagulation agents. But at the same day, she re-admitted to the ER with the acute decompensated heart failure. This patient came from the Gilgit for the coronary angiogram because of the ejection fraction of 40%. This technically difficult study because she has a very low body surface area of weight of about 45 kg female. That was technically very difficult to get the images of the patient, but we try our best to get the translucent images. On this parasternal long axis view, the aortic valve seems to be mild to moderate aortic regurgitation. Just on the basis of this view, aorta seems to be dilated. What's the ejection fraction on this image? Can you have an idea? Not much significantly reduced, it is 40-45 with minor regurgitation. Apical views, apical of 4 chamber and apical 2 chamber views. Ejection fraction was not significantly reduced, but we have a plan for the coronary angiogram, and the mitral valve shows the mitral regurgitation at least moderate to severe. On the suprasternal noise view, you can see the dilatation of the arch of the aorta, but the aortic reversals on the descending aorta, not very significant holodiastolic reversal. Only the early diastolic no reversal, and the abdominal aorta no significant reversal. So AR is not significant, but mitral regurgitation seems to be significant in this patient. This is the focus view of the ascending aorta. Anybody can have an idea? But not going into the very interactive at this point because of the time shortage. But we come this is a severely dilated ascending aorta with a shadow on the posterior wall of the ascending aorta. But it's not very clear because of the technical difficult study. It's either the thrombus in the aorta or it can be the artifact. We all know that the artifact can present like this. But in the presence of the severely dilated aorta, we cannot miss this finding and we have to look further for this. So what next? What should plan? In this case, this patient has no chest pain, no aortic dissection symptoms at the time of the presentation. But just on the basis of this severely dilated aorta around 62 mm in diameter and with the shadow on the posterior wall, we have planned for the CT aortic. This is the X-ray view and the coronal view showing it's a moving image, not very difficult to understand for everyone. So I quickly move to the image. Ascending aorta. There is a large outpouching from the ascending aorta, likely pseudoaneurysm. It is a contained rupture of the ascending aorta. That was not very clear on the transthoracic echo. On the 3-dimensional echo, you can see there is a clear outpouching of the ascending aorta. This is a moving 3-dimensional view. What next? Send this patient to the surgery or do you need further information?
So Dr. Lubna, there is one question. What about the coronary arteries on CTA?
This patient has atrial fibrillation with very tachycardia in a rate of around 120, so coronary cannot be identified on the CT. We proceed for the aortogram because it is emergency. We have to rule out the aortic pathology just to look at the coronary. Then we have planned for the invasive coronary angiogram to look for the coronary before sending this patient to the surgery.
But that would be an issue because you have probably pseudoaneurysm in the ascending aorta, and now you are planning for invasive angio. So that would be a real problem.
That's why we brought our director, cath lab, Dr. very expertise to get this angiogram done, not by the all invasive cardiologist can do. But with very cautious, we get this angiogram show the normally coronaries. No significant obstruction in the coronaries. What next? Send this patient to the surgery. And which type of surgery? Just to replace the aorta and the aortic valve, or need to further evaluate the mitral valve? Yeah. So we did the intraoperative, preoperative transcatheter electrocardiogram at the midnight around 1 a.m. This was the image. The restricted PML with impaired coaptation, you can clearly see on the fourth chamber, esophagus fourth chamber view. The coaptation is not very good on the two eventual equivalent. On the color, it is very severe MR with a weak cutoff sign. We cannot do the continuity equation in this case because of the simultaneous aortic regurgitation as well as the atrial fibrillation because of the variable stroke volume which we see. We do the PISA, multiple PISA images, and the ERO was 0.4, suggestive of the severe mitral regurgitation. With the T base, we may also look for the aorta or the T, although we have diagnosed on the basis of the CT. The last aneurysm that was not very clear on the transthoracic image. And then we sent this patient for the pental plus mitral valve replacement.
So thank you very much, Dr. Lubna. It was really a nice case. मेरी आवाज़ मेरा ख्याल माइक के बगैर भी आ जाएगी, सिर्फ ऑनलाइन वालों के लिए माइक है. So it was really a nice case, and the usage or utility of multimodality imaging, जो कि यहाँ पर transthoracic echo पे initially the things were not clear, and then CT was done and it showed pseudoaneurysm. थोड़ा सा यहाँ ऑब्जेक्शन था कि CT पे कॉरोनरीज देखना ज़्यादा बेहतर था rather than going for invasive, लेकिन जैसे लुब्ना ने कहा कि बहुत अच्छी तरह से उन्होंने कर लिया and no complication was observed. So this was really a wonderful case, and maybe the case is open for discussion. तो हम पहले ऑनलाइन लोगों के कमेंट्स ले लेते हैं, फिर बाद में यहाँ से लेंगे.
We have seen a lot of pseudoaneurysm because of infection. What do you think? What was the cause of this aneurysm? And the mitral valves definitely on transthoracic, it was showing a severe mitral regurg. So nicely looked at the TOE. One comment was we had a discussion amongst ourselves that if we were going to take this case, we were going with a transthoracic, then a TOE, and then a CT. Right. And then an angiogram. So that was one thing to look for the mitral regurg, that the severity, and always the look for the cause of the mitral regurg. And about the aneurysm, did we had a workup for some infection, or what was the valve type like?
For the treated as an emergency case on the CT, the heart rate was not controlled despite all the maximum medical treatments. The coronaries was not clear. That's why we have to go for the invasive angiogram. On the mitral regurgitation, all that was severe on the transthoracic cardiogram. But we did the TE to exactly identify the mechanism of the mitral regurgitation and any feasibility of the repairs. But it was very impaired population, so it was planned to replace rather than to repair in this case. And for the welcome feverism, the patient has no history of the fever, but we have planned to send for the culture of the aortic valve as well as the aortic pseudoaneurysm from the side of the pseudoaneurysm to further evaluate it, but no obvious cause identified in this case.
So we don't know. It may be infection, or it may be just attenuated plaque and leading to aneurysm formation. So biopsy के बाद maybe things would be clear. So if there are no more questions, we can move on to the third case. Dr. Imran.
Dr. Ayub has a question.
Dr. Ayub, please.
अच्छा एक छोटा सा कमेंट है कि जो सीटी के ऊपर कॉर्नरी इमेजिंग है इन एट्रियल फिब्रिलेशन, ये पॉसिबल होता है. एट्रियल फिब्रिलेशन इज नॉट ए कॉन्ट्राइंडिकेशन फॉर सीटी कॉर्नरी एंजियोग्राफी, लेकिन इसमें ये होता है कि हार्ट रेट जो है वो एक्सेप्शनली स्लो करना पड़ता है आपको, लाइक 50 to 60 के दरमियान में अगर हार्ट रेट लिए हैं तो यू गेट वेरी नाइस कॉर्नरी इमेजेस एज वेल. तो अगर आपने एट्रियल फिब्रिलेशन की सेटिंग में सीटी कर रहे हैं किसी भी वजह से, तो हार्ट रेट एक्सेप्शनली स्लो करके करें तो यू कैन गेट वेरी गुड रिजल्ट्स.
I think that's a very valid point, Dr. Ayub. लेकिन इसमें प्रॉब्लम वही था कि पेशेंट was quite unstable and probably it was difficult to control the heart rate. But you are right, in the presence of AFib you can do the CT after controlling the rate, and maybe we can take the comments from Dr. Imran and Dr. Parveen agar koi comment aapka ho.
Just one thing that for the juniors, that you clarify why you label it as pseudoaneurysm. Pseudoaneurysm of aorta.
तो बाद में सवाल लेंगे, पहले उनके भी कमेंट ले लेते हैं, जवाब फिर उन्होंने देना, माइक उधर
Actually,
आप भी दो।
I was late.
अच्छा तो
But my question is that you can do the CT for the coronaries in case of atrial fibrillation by decreasing the heart rate 55 to 60 or less than 60. And when there is a variation between R wave to R wave is minimal. So you can do
We
it.
do because
But I know the patient was
But in this case, we
unstable.
cannot achieve the
No,
heart rate
it's okay, it's
below the
okay.
100 or 110, and we cannot delay just to wait for the heart rate control and to delay the aortic.
I know the case of the patient.
That's why
I mean, yeah, I was saying in general.
it was pseudoaneurysm because the neck was narrow as compared to the maximum diameter of the aneurysm. That's why it was a punched out lesion. The entry point was around half of the maximum diameter of the.
Was there any history of trauma or something like that?
This patient from the Gilead, no history of trauma, but on the aortic valve we have found a small density, might be some heat, vegetation or the infection. That's why we advise for the culture and the biopsy of that valve as well as from the lesions.
आई थिंक हम यहाँ पर इस केस को एंड कर लेते हैं, वरना टाइम पे हम खत्म नहीं कर पाएंगे। आई एम सॉरी, नॉट टेकिंग फर्दर क्वेश्चंस। जी चले, जुनेद से एक सवाल ले लेते हैं जी, प्लीज।
Thank you very much. Nicely presented. Here's just a quick confusion. Confusion is that in setting of an aortic pseudoaneurysm, would you go for invasive angiogram, or should you have proceeded for fixing the problem with an invasive angiogram, or opting for some other modality? You know, if there is an aortic dissection and you have a pseudoaneurysm, they are going through the aorta for angiogram, would that not be too invasive or aggressive?
आई थिंक ये क्वेश्चन हमने पहले एड्रेस कर लिया है, और इसका जवाब भी लुबना ने दे दिया था कि एज द पेशेंट वाज वेरी सिक एंड इट वाज डिफिकल्ट टू कंट्रोल द हार्ट रेट, एंड एज दे हैड द एक्सपर्ट अवेलेबल जिन्होंने कहा कि वो कर लेते हैं, सो दैट्स व्हाई इट वाज डन इन्वेसिव, बट एवरीवन हैज यू नो रिजर्वेशन अबाउट दैट थिंग।